Syed from Drbeen.com. Today we are going to continue with our discussions, and the drug that I want to discuss today is the Famotidine. Famotidine is part of the Math Plus protocol as well. There is a study that they use, it is a preprint. Still, this is a study that has shown that Famotidine use without knowing the exact mechanism has helped reduce the COVID-19 death rate and intubation rate in hospitalized patients. So because of that reason, Math Plus protocol has used Famotidine in almost all of their phases of the disease. So let's very quickly look at it. This is the, and welcome everyone. Lying guys, I'm seeing you after a long time. Hope you're doing good. So if you look here, this is the prophylaxis for the Math Plus protocol. That is somebody who doesn't have the disease yet, and I hope they never have the disease, but how to keep themselves protected. And in that, in optional, they are saying Famotidine usage 20 to 40 milligram per day. Then if you look at symptomatic patients at home, for them, Famotidine as well, 20 to 40 milligram per day, optional. If I continue here, this is the mildly symptomatic patients, inpatient management. If you see here in green, once again, Famotidine 40 milligram daily, 20 milligram in renal impairment. And we'll talk about it that Famotidine is secreted or removed by the kidneys. So in patients of the renal impairment, it is important to adjust the dose. And then finally, if you see here, this is their full Monty, that is the whole list of drugs. And in that, Famotidine 40 milligram daily, 20 milligram in renal impairment. So we have been talking about this for some time, and I thought that we should look at the mechanism of action for this drug as well. Welcome everyone once again. Let's look at the mechanism of action. So here we are. Famotidine is a H2 receptor antagonist. And today's discussion is to understand what are the H2 receptors, how do they function, and this is really in context of the stomach acid production and the ulcers. And then we would go back to this Famotidin's usage for COVID-19 as well. So look, this is and before I discuss, there are 4 drugs in this category in the H2 receptor antagonist. And what are those? We'll talk about it. The drugs are Cimetidine, Ranitidine, Famotidine, which we're talking about, and Nizatidine. So out of all of those, we're talking about the Famotidine. So look, this is stomach here. Esophagus is coming here. This is stomach, and then this is duodenum. In the fundus of the stomach is like the upper part, the globe-like or the dome of the stomach is called the fundus. Similarly, the part of esophagus that connects with the stomach is called cardia of the esophagus or stomach. So in the cardia region and in the fundal region, there are cells that are called parietal cells. These parietal cells make acid, which is used by our stomach to break down the food products that we eat. So here is a high-level structure of the parietal cell. It has H2 receptors on it, or histamine receptors type 2. Those receptors help these cells produce, or they trigger them to produce hydrogen ions. So if you see here, this is very important for us to keep in mind. This is an ATPase pump. What does that mean? This is a protein that uses energy, ATP, and what it does is, in turn, it moves the hydrogen ion outside and it pulls the potassium ions inside. So that is the exchange it does. It brings one positive in and puts one positive out. So that is a parietal cell and how that works. Let's continue our discussion on how the stomach acids are actually produced. So it looks like a little busy diagram, but we are going to focus primarily in this area. So if I zoom in on this one, this is a parietal cell, and it is in the fundal region of the stomach. And if you look at the parietal cell, there are some things that are interesting. So let's start from here, this part. This is an H2 receptor. This is the histamine receptor type 2. Of course, there are histamine receptor type 1 as well. When histamine, this green triangle, when histamine connects with the receptor, what it does is it increases the cyclic AMP production inside the cell. So it works inside the cell, causes more cyclic AMP to be produced. That in turn causes this pump to work more vigorously or work more. That in turn produces hydrogen ions and throws those ions. This pump then brings those ions out in the stomach. And one disclaimer here, this is more of an illustration. Normally what happens is that there are glands that are here like this, and then in the walls of the glands, these cells are present, and the acids are actually secreted in the glands first, and then from there they go into the stomach. I didn't want to complicate the diagram too much, so I just made a cell directly attached to the fundus. If you see here, the interesting thing is that there are other receptors as well. For example, if you see here, CCK2 receptor or muscarinic receptor type 3, these receptors can also respond to other things. For example, CCK2 receptor can respond to gastrin, and we'll talk about gastrin in a second, or muscarinic receptor type 3 respond to acetylcholine, which is released when we have vagus stimulation, and that is one of the reasons for the stress ulcers that are caused in people who are stressed or business executives and so on. The point here is that there are more than the histamine receptors that would help the parietal cell produce the hydrogen ions or trigger the parietal cell to produce the hydrogen ions. Now the question is, where does this histamine come from? So in the same stomach, in the same layer of the stomach, there are cells that sit slightly deeper than the parietal cells. And these cells are called ECL cells or Enterochromoaffin-like cells. So these are called ECL cells or Enterochromoaffin-like cells. These cells can produce histamine and release it. And now what is the thing that tells them to release the histamine? That is a substance called gastrin. Gastrin is another substance that works on the ECL cells and tells them to release histamine. And then histamine, as we can see here, will work on the parietal cell and tell it to release acids. So don't you think that it would be interesting that, or it would be logical that whenever we need acids in our stomach, and when do we need acids? Whenever we eat food, that is when we need acids to be produced. Now, whenever we need acid, gastrin has to come. So that means there has to be some mechanism in our body, in our GIT, in our stomach, that would detect the need for the acid and then release gastrin. So for that, if you see here, this is, first let's look at this one. This is a cell called G cell. G cell releases gastrin, that then works on the ECL cell, which releases histamine, and the histamine works on the parietal cell, which releases hydrogen ions. Now the question is, where are the G cells and what do they do? So if you see here, G cells are present in the pylorus of the stomach. Pylorus of the stomach or pyloric area is this area where stomach becomes continuous as duodenum or becomes continuous with duodenum. In that area, there are G cells that are present. Similarly, in the duodenum, there are G cells that are present in the duodenum as well. And then in the pancreas, there are G cells as well. So G cells are present in the end of the stomach, in the duodenum, and in the pancreas. And whenever we have proteins in our food, whenever there is food, whenever there is protein, these G cells become active. And when they become active, they release gastrin. Gastrin in turn goes into blood. From the blood, gastrin then comes here and acts on the ECL cells or Enterochromoaffin-like cells, and then you know the rest of the story. So I'm going to zoom this out a little bit and just look at this diagram for a second. And let's start this, that how do we get the acid? I ate some food. Food may have some proteins. Those proteins would cause the stimulation of the G cells. G cells are present in the antrum of the stomach, pylorus of the stomach. They're present in the duodenum and pancreas. G cells in turn would release gastrin. Gastrin would go and act on enterochromoaffin-like cells or ECL cells in the stomach wall. And those ECL cells would in turn release histamine. Histamine would then work on the parietal cells and ask them to release hydrogen ions. Hydrogen ions in turn will then help digest the food. Now these cells, the parietal cell, in this diagram, I have actually made a gland. As I said before, this is a gland that is attached to the stomach, and there are many millions of glands. These are microscopic structures, and they have parietal cells in them. One quality of the parietal cell that is very interesting is that a parietal cell in our body, in the vertebrates, all the vertebrates, these are the only cell that can create a pH difference which is tremendous. What is the pH difference they can create? Their own internal pH is 7.3. So sort of normal pH for other cells as well. However, they can release so many hydrogen ions that the area where they throw those hydrogen ions, the pH over there drops down to 0.8. Very acidic, very acidic. So this lava, if I can call this lava is then released from these glands into the stomach, and that is when it goes and helps digest the food. So parietal cells are, of course, very, very important. Now, a couple of things that are interesting for us to keep in mind here. Those are, if these glands, if parietal cells are so strong, and if they can produce such a high acidity in the stomach or such a low pH, then what will save our stomach from becoming digested by these acids? So for that, if you see this little green dude over here, this cell is a mucus cell. This cells most abundantly are present near the pyloric area as well, or on the pyloric area. These are called mucus secreting cells. What they do, their name is superficial mucus secreting cells. What they do is that these cells produce mucus and they keep secreting that into the stomach. That mucus that is secreted in the stomach, mucus is like a thick substance, jelly-like substance. When it is secreted, it is slightly less jelly, but when it has been secreted and it goes in the stomach, it becomes more jelly-like, and it creates a protective covering on the walls of the stomach. And that is how the stomach protects itself from the acids. There are more mechanisms as well. For example, bicarbonate is released near the duodenal area as well, and lies the hydrogen ions and neutralize the acids there. But this is important for us to know that the mucus cells are also present. This, by the way, these mucus cells, they respond to PGE2 and PGI2. Remember prostaglandins and prostacyclins? Let me just very quickly review that. This is the discussion of the aspirin or NSAIDs now, that why do NSAIDs cause ulcers? So look, we talked about it, that in the cell membrane there are lipids, correct? Phospholipids. Then there is an enzyme called phospholipase A2. That enzyme breaks down the lipids to arachidonic acid. This arachidonic acid, in turn, with the cyclooxygenase enzyme 1 and cyclooxygenase enzyme 2, can be converted to PGE2, PGI2, etc. And we have done this discussion very, very many times, because when we were talking about the coagulopathies, that is when we talked about these enzymes and PGE2s and I2s. Similarly, if over here we have lipooxygenase pathway enzyme, then the arachidonic acid is converted into leukotrienes, leukotriene B4, leukotriene C4, D4, E4, etc. So these are the products of the arachidonic acid, or the phospholipids. These products act on the mucous cells, and then mucous cells in turn makes mucus, which protects the stomach. Now, what happens is that when we give NSAIDs, these are the painkillers which are not steroidal. When we give NSAIDs, they block this area, cyclooxygenase pathway. That causes a reduction in the PGE2 and PGI2 production. And now if you go back here and see this cell needs PGE2 and I2 to produce mucus. So when we give non-steroidal painkillers, they would reduce the production of PGE2 and I2. In turn, the mucus cell would reduce production of mucus. That would reduce the stomach lining or protective layer on the stomach will be reduced in turn. And when the protective layer of the stomach becomes thin, then it is easier for the acids that are secreted by the stomach to start causing damage to the stomach. They would start digesting the stomach itself. They'll think that this is another muscle, this is another protein that the person has eaten. They would just start working on that as well to digest that. That is how the ulcers would start developing when people are taking non-steroidal anti-inflammatory drugs or painkillers. Now, going back here, I also want to just very quickly mention this. This M3 receptor over here responds to vagus stimulation. And this M1 receptor over here also responds to vagus stimulation. So vagus is a nerve that comes from our brain and it supplies our viscera. And the vagus nucleus and hypothalamic nucleus in our brain, they can send signals which can then trigger these cells, which in turn can make histamine, which would then cause acid secretion, and that would increase the acid levels. And this vagal stimulation can occur because of stress as well. So normally, people who are under stress, they may develop ulcers because of this mechanism. So I hope that this much is clear. Any questions here before I move to the next diagram? Okay, so I think that this is clear. This is clear. Now let's look at the mechanism of action of famotidine. Famotidine in turn, so if you see here, this blue thing is famotidine. This is a receptor blocker for H2 receptors on the stomach. So what happens is when we take famotidine by mouth, or it can be given by IV as well, famotidine gets absorbed, then it goes and blocks the H2 receptors. When the H2 receptors are blocked, if you can see here, histamine is standing confused over there. Why? Because it doesn't have any place to go and attach. So the result will be that the parietal cell will not make as much of the hydrogen ions as they normally produce. And how much is the change? Parietal cells' production of acid is reduced by 70%. Reduced by 70% for 24 hours. And by the way, just one more note over here. This is something that happens to almost all of us: heartburn and gastritis and ulcers. So probably it is relevant to all of us. Nowadays, proton pump inhibitors are the drugs as well that are more used than the H2 antagonists. So these are the prazoles like omeprazoles and others. Those are called PPIs. What they do is that they directly work on this proton pump. And do you know how they work on that? So the proton pump, let's say this is the ATPase, and this is hydrogen removed, potassium brought in. It uses ATP. And when we give proton pump inhibitors, they act as sulfa breaking enzymes. They become converted into an active metabolite, which then goes and works on this pump and breaks its sulfahydryl groups. So we have talked about the sulfahydryl groups a lot with N-acetylcysteine, with glutathione, and a few days ago we talked about the sulfahydryl groups as well in terms of favipiravir. So sulfahydryl groups are broken. That causes the pump to become inhibited forever. Now, does this mean that now this pump is gone and we cannot make more acids? No, we keep manufacturing new pumps all the time. We manufacture them, we store them in the cell, and whenever we need them, we can release them and they can go and get attached in the cell membrane. So this is, although that any pump on which they act, that particular pump becomes disabled forever, but that pump is recycled very soon and it is removed and a new pump comes in. So still proton pump inhibitors. So these drugs that disable this pump are called proton pump inhibitors. These are more popular nowadays than the H2 antagonists. Still, H2 antagonists are used. So 70% reduction in acid secretion for 24 hours. Now, normally they are given at night or in the evening because the best action of an anti-acid drug that we need is while we are sleeping. The reason that we need it at the night time is that our stomachs are usually empty at that time, and the acids are sitting in empty stomach and they have no other food to work on, so they would rather start working on whatever tissue is nearby, and that is the stomach itself. So because of that, to have our ulcers heal better, we should use these drugs near the evening or night so that the stomach, which is empty, gets a break and the ulcers get a chance to heal. So hopefully the mechanism of action is clear. Now let's look at the administration, metabolism, and excretion. So these drugs, the H2 antagonists, they are rapidly absorbed when given by oral pathway. They can be given parenteral as well. That means other than oral, for example, IV2, but they are rapidly absorbed. There's a comment that from Kevin that eat late. The problem with the eating late is that also causes indigestion and that also can cause acidity. So best is that if, number one, hopefully none of us develops the ulcer, but if the ulcer is developed, then the best way is to eat early and then take these things, the H2 antagonist or the drug, whichever drug you're taking, near the evening. So rapidly absorbed, their peak serum level concentration. So here, let's say they are administered at hour 0. When they're administered at hour 0, they start becoming active within 1 hour and their peak level reaches between 1 to 3 hours. That is when their peak effect comes in. Their half-life means that inside our body, their level would drop to the half of the original. Their half-life is 1 to 3.5 hours. So within this window of time, their level will become half. Then in another 1 to 3.5 hours, their level will become half again, and this would continue. Then a smaller amount of them, usually when we take drugs, many of the drugs go and they become bound to plasma proteins, mostly albumin. So in this case, a very tiny amount of them is plasma protein bound. This drug is mostly running around free in our blood. These are excreted by kidney. And because of this, because they are excreted by the kidney, anybody who has renal impairment, especially the glomerular filtration, or if they have the kidney's nephron disease, then the dose should be reduced. And this is why, if you see here in the Math Plus protocol, they're saying Famotidine 40 milligram per daily, 20 milligram in renal impairment. And the reason for that is that this drug is secreted by the renal tubules. So if the kidney is damaged, then the drug cannot be secreted easily, and then we have to reduce the dose. Liver metabolizes about 10 to 35% of this drug, mostly lesser than 10 or lesser than 35. Because of this, people with the liver disease do not need to have the dose adjustment because liver's role in metabolizing this drug is smaller. So continuing on, usage. What are the diseases in which Famotidine is used? So this is, we're talking other than COVID-19. COVID-19, it is not a direct drug to fix COVID-19 or to treat COVID-19, but it is seen, I'll show you the study, it is seen that it is helpful in that it reduces the intubation chance, risk of intubation, and risk of death. So I'll show you that study in a second. But generally, Famotidine is used for esophagitis, that is the inflammation of the esophagus. That can occur, like yesterday we were talking about the pill esophagitis. That was because of the pill that the person was taking in yesterday's discussion. Gerd, or gastroesophageal reflux disease, that can occur because of some mechanical issue, at the sphincter of the esophagus with the stomach. So the stomach acids can reflux backwards into the esophagus and all even come into the mouth as well. So that is Gerd. And so it is used for Gerd as well, heartburns as well. Then stress ulcers. The stress ulcers can occur, as I spoke before, because of a person being stressful. That causes vagus stimulation that can cause the acid production. Burns can also cause acid production by similar mechanism. Then Zollinger-Ellison Syndrome. Zollinger-Ellison Syndrome is a kind of a problem with the stomach. There are tumors in the stomachs that then produce a lot of acid. Multiple endocrine adenomas, another disease in which acid production is increased. There are many endocrine gland tumors all over the body. One of that is the tumors, the glands in the stomach are also more and they're working more. Gastric ulcers, although I think I've made them in the wrong place, they usually are more frequent here. But anyways, gastric ulcers are, of course, a very important target of this drug. Duodenal ulcers are another important target for this drug, part of the drug regime to help eradicate Helicobacter pylori. So Helicobacter pylori has been incriminated now, has been seen to cause gastric ulcers as well. So there are antibiotics that are given for the Helicobacter. There can be PPIs given, proton pump inhibitors given for the Helicobacter as well. However, in some combinations, sometimes H2 antagonists are also used. And of course, as I discussed before, the NSAID related ulcers, we can give the H2 antagonist as well. So if I go back to that diagram for a second, so imagine that the person is taking painkillers, and because they're taking painkillers, there is a risk that their mucus secretion would become less. They would start developing ulcers. So the best thing to do with that is that we also reduce the acid secretion. Of course, remember, when we would reduce the acid secretion, then digestion itself will become affected too. So it is not that any time somebody takes a painkiller, we also give them the Famotidine. It should be sparingly used, or it should be used in those who have ulcers or have a tendency to develop ulcers fast. So for them to prevent those ulcerations, we can reduce the gastric acid production by giving either PPIs or H2 antagonists. So back here to the usage. So prevent NSAID-induced ulcers. Then these are also given before the surgery to reduce the risk of aspiration pneumonia. So in some surgeries, when the patient is becoming conscious again, during that time, it is possible that their stomach content and the acid from the stomach, normally the patient is they have not eaten anything before the surgery, but there are acids that have collected in the stomach. Those acids can actually come back up in their mouth or the pharyngeal area, and from there they can then go back into the tracheal system or the airway system. Over there, the acids that go in the airway can cause serious injury, and then the infection can occur. So that is the aspiration pneumonia that can happen. So sometimes before the surgeries, these are given to reduce the acid production in the stomach. And the last part of the discussion today, side effects. So one thing that I wanted to make sure that we all keep in our mind, because hydroxychloroquine causes QT interval prolongation, azithromycin causes QT interval prolongation, and then the H2 antagonist can also cause QT interval prolongation. So these drugs, when combined together, can become quite dangerous for COVID patients who are treated with this kind of a combination. So just keep that in mind. Normal, common, although not very common, but if the side effects occur, more common side effects are headache and dizziness. And then other constipation and diarrhea, constipation or diarrhea can also occur. Other than that, fatigue can occur. If it is given in IV, for example, in hospital, if given IV, they can rarely cause more CNS issues, for example, confusion, delirium, hallucinations, slurred speech, and headache. And then there is a possibility, there are some studies that have shown that when famotidine-like drugs are taken, they can cause blood disorders, especially thrombocytopenia. That is, thrombocytes are the big cells. Remember, we talked in the hypercoagulability that there are big cells in the bone marrow, which are the thrombocytes or megakaryocytes, which would then make small platelets, which are thrombocytes, and those thrombocytes would then help with the clotting. So this drug can actually cause thrombocytopenia. That means it can reduce the level. Maybe it is useful in COVID because it reduces the level, but I would rather use anticoagulants than famotidine for that effect. And the last part, before we see the study, is the caution here. Famotidine can cross placenta in pregnant women and go to the children, or go to the fetus, children. And secreted in the breast milk as well. Although it has been seen to be safe, and that is why these are over-the-counter drugs, because their safety margin, their safety profile is very good. Still, there is a caution not to use them in pregnant women or women who are breastfeeding the children. So with this, let's look at the study. So here is a study, again, full disclosure here. This is a preprint, not been peer-reviewed. So this was a 5-1. So May 1, maybe by now it may have, I have not followed up further on it. But what they had done was they had seen, this is a observational study, retrospective study. So again, it is not a prospective double-blinded kind of a study. What they had done was they had looked at famotidine use and the suppression of the COVID-19, and their endpoints were they were looking at people who got intubated after using the famotidine or who died. So what they saw was use of famotidine was associated with reduced risk of death or intubation. And this is very important. Last time when we were talking about Math Plus protocol, somebody had sent me this note. I think many folks had sent me this question that why not we use proton pump inhibitors, because the audience were thinking that maybe somehow reducing the acid levels were helpful. So it is not about reducing the acid levels in the stomach. It is the famotodine's own function, some unknown function that is related to the reduced risk of death or intubation in COVID-19. What is the exact mechanism is not known. So they have said this over here categorically. Proton pump inhibitors, which also suppress gastric acids, were not associated with reduced risk of death or intubation. So this is the discussion for today. Hope you enjoyed it. Do me a favor, if you enjoyed it, please like, subscribe, and share. And we would see each other tomorrow. Bye-bye for today.